these webinars, it is kind of as we advertised as an open forum. So if you do have a question, please enter it in the chat box. You know, it's meant to be kind of a two-way dialogue. We can certainly unmute somebody if we need to get into a more specific question with additional details. So let me see if I can turn on my mic. Can everybody hear me? I'm going to make a quick adjustment here.
Yeah, I can hear you.
Okay, you can hear me. Do I sound okay?
Yes.
Okay, excellent. Thank you for verifying that. If you do have a question, please go ahead and get that get it entered into the chat box, so we can have that two-way dialogue and we can have some questions and answers for everybody's questions. I'm just trying to think here. So we do have Katie on the line with us. So Katie is kind of our partner organization with AHI. Together, Fort Drum Regional Health Planning Organization and AHI forms the telehealth partnership. So we collaborate on a lot of different things as it relates to telemedicine and telehealth. And I appreciate all the hard work that Katie has done. She's really been putting in some long hours trying to decipher all these waivers that have been coming out as well. So the one quick, we still haven't got any messages. So once again, please, you know, if you got questions, go ahead and enter those in the chat box so we can start answering your questions that you do have. I do have one quick update for those that are participating with Healthy Connections. So if your Rio is Healthy Connections, they did send out a notification that they do have results for COVID-19. So there are some stipulations on if you can see those under specific circumstances, but if they are a patient of yours, or if you were the ordering physician, you should be able to see those results, or if they're a patient of your practice. So, so those are one of the new things that you know, that is being kind of tracked from the Rio side. Do you have any updates? Anything new? Anything new for waivers, Katie? Anything in the past couple of days?
Do I have updates? I have updates. So the biggest one so far, and I want to keep this obviously primary care and hospital focused, CMS. So over the weekend, the CARES Act was passed, as many of you saw from our update earlier this week. Medicare then released additional changes as of March 30th, so Monday. So at a high level, CMS added to the list of services that can be provided via telehealth to include additional hospital services and home visits. They also now said that inpatient, neonatal, and pediatric critical care and intensive care codes can be performed via telehealth. Additional services that are temporary additions include care planning for patients with cognitive impairment, psychological and neuropsychological testing. All of these services are for new or established patients. The previous subsequent inpatient telehealth rule was once every 3 days you could have a visit. That has now been waived, and you can do this daily. In order to bill Medicare office visits or any of the services I just mentioned, it has to be telemedicine, so interactive, two-way, real-time audiovisual with the patient. If you're using the phone, they have also come out with information on that. So CMS will now pay for phone calls using codes 99441 to 99443. Those are the same codes that the New York State Department of Health for Medicaid has also said are now valid to be billed for telephonic encounters. CMS has also stated codes 98966 to 98968 can be billed. So what's the difference between those two sets of codes? So physicians, nurse practitioners, physician assistants, clinical nurse specialists, and certified nurse midwives can bill 99441 to 99443. Registered dietitians, social workers, speech language pathologists, and physical and occupational therapists would use 98966 to 98968. There's obviously a much lower RVU with telephone codes. The rates are averaging around $13 for 99441 up to $39 for 99443. And pretty much the same for the other three codes if you're not a licensed physician or mid-level. So per the CPT definition, the phone call codes are services initiated by the patient, but CMS did not discuss if this requirement was waived or not. And additionally, they may not be provided if they are in a follow-up, if it's a follow-up for a visit within the past 7 days, or if it results in the patient needing an appointment in the next 24 hours or soonest available appointment. These codes were obviously previously non-covered, but now are, and you do not need real-time audio-visual equipment for those codes because they're not considered telehealth services. So those were some big updates from CMS. In addition, there was a lot of CMS updates, so I apologize. So for office and hospital visits and other services allowed via Medicare's existing policy, this does include psychiatric diagnostic interviews, psychotherapy, wellness visits. The provider must use, of course, interactive two-way audio video for codes 99201 to 99215. If your patient does not have access to a smartphone or computer, you would not bill these codes. As many of you know, the HIPAA privacy rules have been waived. So they are stating, Department of Health and Human Services is stating that things like FaceTime, Skype, Google Hangout, Facebook Messenger are now allowable applications. I don't know about you, Tom, but I am strongly recommending that partners try to seek out HIPAA compliant technology platforms before they resort to FaceTime. You know, you want to think of the long term here. I know that right now everything is really focused on COVID-19, but if you're going to continue to offer this type of service to your patients beyond the pandemic, you want to make sure that it is HIPAA compliant, because I cannot imagine that HHS is going to continue to allow FaceTime to be used beyond the pandemic. Tom, do you have any thoughts on that?
Yeah, I certainly agree with you. And the whole key thing is with kind of what is being referred to as a quasi suspension, of HIPAA. It's within what's called good faith. So if you broadcast that telemedicine visit somehow accidentally on YouTube, that's not really within good faith. So they're expecting people to still use good due diligence. And if you're not able to implement a HIPAA certified one already, that you have done due diligence to ensure that you're providing a certain level of protection and privacy for those encounters. So it's within good faith. If your only option for a critical patient is FaceTime, then sure, but understand that it is only to be used within the COVID-19 emergency, as I believe all these waivers that you're talking about as well. Once these declarations go away, everything's going to revert.
Yeah.
So it's one of those things. If you don't have any other solution, obviously care to our patients is the most important thing. But we're certainly steering people, to stay along with, more along the lines of, if you have an add-in for your EHR or EMR in your practice, I would go that route primarily first. If there's hurdles that you can't, you can't kind of bridge, then, then we can, you can potentially look for different actions. So, So I am getting a couple comments that my voice is fading in and out. So I'm gonna see if I can make an adjustment on that. I don't know how I sound to you, Katie, but
You sound fine to me.
okay. So I'll try to make some quick adjustments, but that's kind of my 2 cents on the HIPAA aspect. I've been getting a lot of questions. Regarding what that means with good faith. So
Sure.
yeah, so we did have one quick question, and I do want to emphasize that this is primarily primary care and hospitals. We're going to be doing behavioral health specifically tomorrow, just because it opens up a whole other can of worms. But we did have one quick question. Is there any guidance for behavioral health and just phone calls? So and
Um,
the two-way video conferencing?
I'm going to put my OMH hat on here. And I don't know if that's the right hat to put on because, again, that is for tomorrow. But OMH for the OMH licensed clinics and designated services, including residential, they are allowing telephonic encounters. So that is allowed with OMH. They are stating that you would bill the normal CPT code as if the person was in front of you and append the 95 or GT modifier. So that's a little bit different than what DOH or CMS is saying. So I hope that answers that question. And I did want to touch on something from CMS while we're still kind of on the CMS train here. CMS came out on Monday with a very interesting change. In relation to the 99201 to 99215 office hospital visits. So as of March 30th, CMS said you're no longer required to use place of service code of 02, but instead should use the place of service that would have been used if the patient was seen face-to-face. So this means that the office visit services will be paid at the higher non-facility rate and not the lower facility rate. So if the person that you're seeing, if you use a POS 11 normally for an office visit and you're in the office, use that. If you're a provider that's practicing out of your home, you would use POS 12. Additionally, CMS wants you to use modifier 95 on the claim form. This is very different from previous CMS guidance, which has always been place of service code of 02. But please keep that in mind. It's no longer place of service code 02, but the place of service that would have been used if the patient was seen in person and modifier 95 on the claim form. This is separate and apart from the virtual check-in and digital e-visit codes. This would not apply to those. You would not use place of service code 02 for those services. Those are not considered telehealth services. Sandra just asked the question, should we use 95 for phone visit only? No, I am talking about telemedicine here. Telemedicine visits 99201 to 99215 is where you would use the 95 modifier and the place of service code if the person was in front of you. For phone calls, you use the 99441 to 99443 if you're a physician or mid-level, and 98966 to 98968 if you're a dietitian, social worker, speech language pathologist, or physical and occupational therapist. And for those that are asking about a recording, yes, we are recording it and we'll send it out after. Tom, do you want to take a look at some of these other questions that are on here?
Yeah, absolutely. We got a couple coming in here. So let's see. Okay, so we do have a question from actually our medical director for Fort Drum Regional Health Planning, Dr. Leindecker. So he's kind of touching on the point, is there any specific verbiage that we should be documenting during a telemedicine visit? So before I kick it over to you, because I'm sure you got some input on this, if you are referencing anything in Healthy Connections or your Rio, so if you're doing any of your HIE access, you need to specifically document that a patient has given you a consent to access their information through the Rio in your chart for during this COVID-19 emergency period. So if they haven't consented before and they're giving you a verbal consent, you just need to have that documented, in your medical notes. So that is the piece that I have for documentation, and I don't know if you have anything or not, Katie.
So are you talking, I'm sorry, you're talking about consent? I was looking at something else about FQHCs to answer the next question.
Yeah, no, I absolutely. So my input was that there is a requirement for consent for HIE. So like in our region is Healthy Connections. So if you're gaining patient information on the Health Information Exchange, that needs to be documented. That consent was given to you in the note. The question was from Dr. Leindecker is if there's any specific verbiage that should be used when documenting a telemedicine visit.
So what I'm seeing is obviously written consent is not required right now. The practitioner shall provide the member or legal representative with the basic information about the services they're going to be receiving via telemedicine or telephone. And the member or legal representative shall provide his or her consent to participate in services utilizing this technology. This should be documented in the medical record, and these services shall not be recorded without consent. There is nothing around specific exact verbiage around how to best document this. I feel like, patient XYZ consented verbally at this date and this time to these services. I think something standard like that would suffice.
Yeah, and I certainly agree. Anything that you would get written consent for, I would just use use some sort of verbiage that they have actually consented to treatment and that stuff. That way, the written authorization is waived, but you still want some sort of documentation someplace that you can potentially fall back to.
Mm-hmm.
Agreed. So one of our, I don't know, I know you probably haven't seen it yet, and I could be wrong, you may have seen it. So I know Greenway EMR specifically had a really good screenshot of the codes and modifiers for people to use. So she's going to send that to me in an email, and I'll share that with Katie, and we may provide that as a reference. So we may have some additional good references, but I know you have some codes available as well, some of your documentation that can be used for reference as well. Let's see what else here we have for questions.
There's a few questions around FQHCs and the PPS rate.
Yep.
Versus the calculated fee for service schedule rate. So I'll touch on that a little bit. So I'm referencing the Center for Connected Health policy. This was as of yesterday. So the CARES Act kind of removed some language that the previous act had put in place. So under the new CARES Act, HR 748, of course, FQHCs and RHCs will be allowed to act as distant site providers for reimbursable telehealth services under Medicare. This is, of course, not a permanent change and will only be in effect during the emergency declaration, but a few other things to note. The Secretary shall develop a special payment methodology to decide the amount of reimbursement the FQHC or RHC will receive when acting as the distant site provider. This methodology will be based upon payment rates that are similar to the national average payment rates for comparable telehealth services under the fee schedule. Costs associated with telehealth delivered service will not be used to determine the payment amount for PPS or AIR. CMS has not issued specific guidance yet on how it will implement these changes for FQHCs and RHCs. So I hope that answers the question. I know it's still a little unsure and vague at this time, but without guidance, we can't, we can't provide much more.
So I see that Josh, have kind of put a question / comment in there. So it says CMS stating that you can no longer change places of service to O2, but does this apply to all insurance companies? And you can correct me if I'm wrong. We're specifically speaking to regarding CMS.
Yeah.
Private payers, I know Katie has done an amazing job on documenting information that we're getting on what different payers, whether it be Excelis, and some of the other payers. But as far as like private payers, there is documentation out there. They're all kind of doing their own thing.
Yeah.
So you can reference the two, reference either one of our sites, AHI's site and FDRHPO's site. They have some really good. They have some really good information on what they currently are doing, but I would always call to verify specifically as it relates to your practice. So
Sure.
I don't know if you have anything to add in besides that, Katie.
I would reiterate that the private payers, some tend to follow CMS guidelines. some tend to follow state guidelines, and it's really hard for us from our perspective to get a good grip on that. Reason being, you know, we're performing provider systems, so we're not providing direct patient care. Therefore, we are not billing and don't really see the ins and outs of telehealth billing the way that all of you do. So we have to rely on information that's either sent to us or is found publicly on their websites, which oftentimes leaves us without a lot. So your best bet is to reach out to your provider representative, whoever does your contracting, and they should be able to tell you the right way to bill.
Excellent. Yeah, it's kind of a moving target with some of the private payers. So definitely reach out, double check. We're trying to document stuff as we learn it, but it doesn't mean it hasn't changed too. So it's just one of those things. Let's see what we have for questions.
I want to address Christine Leibold's question. I think that's the next one we haven't gotten to.
Okay.
So as I'm reading it, and I'm referring to a website that has a really great overview of this stuff, codingintel.com. The requirement to use place of service code 02, is this only applicable to the new codes added for the duration of the public health emergency? I am not reading it as such. The way that I am reading this is that the new codes that have been added, as well as the pre-existing E&M codes, all need to be switched over to modifier 95 in the place of service of where the patient would be seen normally. So I hope that addresses your question. If you have concretely seen otherwise, please let us know. We don't want to be spreading this information by any means, but this is how I am interpreting and reading the guidance.
Yeah, and that normally goes for the typical waiver. Actually, I kind of forgot to do this at the beginning, but neither one of us are attorneys. We're not. What we're doing is, this is our interpretation, and this is information that's being fed to us. So we're trying to share information. We're trying to vet all of our information that we get. But one of the things we're running into is things are changing so rapidly. It can be very difficult to ensure that we're 100% accurate. So we're always asking people that, take our advice with, somewhat with a grain of salt. Please do some verification on your end as well. We're doing everything we can to make sure that everything we tell you is correct and as true as possible. But there's still that chance. So
sure.
Yeah.
The next question that has been unanswered is from Sandra Birch. I actually want to unmute your line, Sandra, just so I can get some clarification on your question around how much you actually bill for, since there's already set payment amounts. So you're unmuted, Sandra. Sandra does not have a mic. Okay.
Okay.
So we'll do our best to try and answer this. She said, does it matter how much you actually bill for, since they already have a set payment amount? I think she's referencing the telephone CMS codes, and please chime in via chat, Sandra, if I'm correct in assuming that. I haven't seen any guidance on utilization. Typically CMS comes out with comments with the annual physician fee schedule that they will monitor utilization of new codes. I haven't seen anything on utilization of these previously non-covered telephone codes. Tom, I don't know if you've seen anything.
I have not seen anything in regards to that.
My educated guess here is that, they're going to monitor utilization, but given the emergency that we are in, I don't think it's going to matter that much how much you bill these codes, so long as you're following the 7-day and 24-hour rule. That's going to limit you somewhat with these telephone codes.
Yeah, and I completely agree with that. So it looks like that answered Sandra's question. So that is.
So next up, we have a question from Alicia Short. We have been advised to use G2012 for all phone call visits billed for Medicare patients. has this changed to 99441 to 99443 codes. Alicia, I'm going to unmute you for a second and find out who advised you that. You're unmuted.
Hi, Katie.
Hi.
Just so we've been advised by our coding advisors to only bill G2012 for Medicare patients, not a 99441 to 443 code.
Right. And was this as of how recently were you advised this? Because CMS only made these codes covered in the last like 48 hours.
I was emailing with her yesterday.
Okay.
Yeah.
So that's a valid point because G2012 is very similar to the 99441 to 99443 codes. The key difference here is that the G2012 code also gives you the option to use telemedicine to get back with or to engage with the patient. So G2012 is a patient-initiated code, much like G2010, has to be with an established patient. There is that same 7-day, 24-hour rule. I haven't seen anything on CMS liberalizing this, but the key difference here is that G2012 also allows the option of telemedicine. You can still do telephone with G2012, but there is a 5 to 10 minute window with G2012, whereas the other three codes, the 442 and 443, give you the option to discuss beyond 11 minutes all the way up to 30.
So it should either be one or the other.
Yes and no. So again, G2012 is just that short amount of time and gives you the telemedicine option. Whereas if you want to use 99441 instead, the RVUs on those are about the same, to be completely honest. I think G2012 carries about maybe $1 or $2 more. So neither is right or wrong. There's just some subtle differences. 99441 being telephone only, G2012 giving you the option for that virtual communication.
Okay.
To further confuse you.
So we only have the option for phone right now. We don't have an option for video. So
it's, again, you can use either.
Okay.
I don't know what might be easier for your practice. That's a determination to make on your end. But as I'm in understanding these codes, you can use either. G2012 has been around since January 1st, 2019. It's just always been dubbed the virtual check-in code because you're using telemedicine, but telephone is also an option.
Okay.
Tom, any other thoughts on that?
No, I completely agree. You're definitely a little bit more up to speed on the billing than I am. Billing is definitely not my specialty. I'm more on the tech side, so I'm glad you're as proficient with it as you are. So, so no, I don't have anything more to add on that.
Okay, and I actually just got a wonderful update from my colleague Nancy Del Mastro at AHI. So thank you, Nancy, for clarifying this. She just sent me a link which I'll be able to share with the group. So CMS came out with a document yesterday that actually does not mention removing place of service code of 02 for traditional telemedicine. They're stating traditional Medicare telehealth service professional claims should reflect the designated place of service code of 02 telehealth to indicate the billed service was furnished as a professional telehealth service from a distant site. There is no change to the facility or non-facility payment differential applied based on place of service. Claims submitted with place of service code 02 will continue to pay at the facility rate. So that's an important distinction. I was not aware of that. So I thank you, Nancy, for clarifying that. You are a rock star. So that goes back to Christine's question, which I apologize, I answered incorrectly. So traditional Medicare telehealth services would still use 02. The newly added codes, which includes some hospital-based services, would use the place of service code that would normally be used if you saw the patient in person. So I hope that that clarification makes sense. I apologize for interpreting incorrectly. Lots of information coming at me, so that is my bad.
Yeah, it's one of those things. The information is changing so rapidly. We're trying to interpret everything as quickly as we can. So, I know there was a comment that somebody, they didn't have the video capability yet, and I know Sandra also recommended to Alicia that the Doxy.me application. So if you don't have capabilities within your EMR, so some EMRs currently have have a telemedicine or a virtual visit capabilities. If you don't, there are several several applications that are out there. I know a lot of people have started to use the Doxy.me application. It's a great application. I've kind of demoed it a little bit. It's a great alternative if you want to extend that video component to your visits.
Excellent.
Yeah, and it's free. Thank you. That's always a key, and the price is right. So
we got a question from Felicia Parker. Does that hold the same for the virtual check-in codes for FQHCs, similar to 99441 to 99443? I have not seen anything on this yet. That could just be because I haven't noticed it, but with the guidance continually updating and CMS now allowing telephone codes only 2 days ago, I'm not seeing anything that's stating FQHCs can or cannot bill those codes. I know for the virtual check-in codes for FQHCs, they have to utilize G0071 instead of G2012 and G2010. But I haven't seen anything yet stating you can't bill the telephone codes. If anybody else on the line has seen otherwise, we may be the experts, but I certainly rely on all of you for more specific information you may be receiving based on your practice type.
Yeah, exactly. And actually, to add to that last comment, Sue just kind of chimed in saying that additional for, and this goes back to the question that Dr. Leindecker had as far as specific verbiage to have in your charts. And the recommendation that she's giving is there was an advisement to add, including the verbal consent, the provider must include the number of the minutes spent with the patient. These are time-based, and also the provider's location and the patient's location for reference. Later on and in the future. So that's a great recommendation. The more information you can provide in the chart, really the better. As we try to get clarification, or if there's different interpretations to these rules, it's nice to have all that information available.
Yes, and thank you, Sue, for pointing that out. A lot of these codes are time-based, so you want to know how much time you spent, discussing plan of care with the patient.
Excellent. So I think we're caught up for questions right now. So if you're hanging on to a question, if you got something that you want to run by either one of us, please go ahead and submit your question. If it's something more in detail, we can certainly unmute your line as well. We can have a further conversation on it. I just want to give people a reminder that when you make that, if you're not currently doing telemedicine in your practice, there are some considerations that you need to make sure you're keeping in the back of your mind. If you have never done telemedicine, specifically a video, so there's audio and video two-way, make sure that you're paying attention to where you're actually doing your visit. And I don't mean as far as billing reasons. I mean as far as quality of your video, interruptions. You want to make sure that you're not running off of cellular. Preferably, you want to be at your home location or your business location. If you have capabilities of doing it from a device that is plugged into the wall, meaning hardwired with Ethernet cable, that is going to be your best and your most reliable scenario. Specifically because wireless has the inherent nature of being unreliable sometimes. It just you can have interferences that are kind of out of your control. So, and also if you're a bigger practice and you're doing multiple video consults, all of a sudden you need to be mindful of your internet connection. There are some requirements that you need to make sure that you're paying attention to. You are only going to be able to sustain so many high bandwidth encounters at the same time. So just something to keep in mind if you're going to start implementing this and you haven't done it previously. There's some technology requirements you really need to just to take a couple minutes and plan ahead. So looks like we've got a couple other things coming in now.
It looks like Holly sent a link to the Medicaid update. I don't know if that link would be valid in the chat, but we'll be sure. You know, I have the registration list from Tom, so I'll put a quick follow-up email together with some resources that I've referenced throughout this discussion, as well as DOH came out with a 26-page FAQ document that I've been trying to look through today, and it really does get into some extremely specific situations relevant to FQHCs, billing APGs, Article 28. So I'm going to include that so that you guys can kind of look through that and, you know, just do a quick word search. I think the billing section alone is like 10 pages. So yeah, thank you, Holly, for sharing that.
And then I think Christine's got another question. Would you expect the 98966 to 98968 to be billed with the MPFS even when performed by a dietitian, for example?
Under the fee schedule, I don't have an answer for that. I don't know. I don't know. I don't have an answer for that. If were those codes under the fee schedule previously, I'm guessing not if they were non-covered, but this is where not being a biller doesn't help us.
Excellent.
Yeah, I'm sorry, Christine. I don't have an answer for that, but we'll note that and look into it.
Perfect.
Oh, okay, interesting. Yeah, I don't know. They are covered under the fee schedule, but most of these providers typically normally bill under ops. If we find any more clarification on that, we will definitely let you know.
Excellent. Yeah, I was going to say that you know, we strive to have answers to everything, but I was expecting that there was going to be some questions that we just didn't know off the top of our head, and if we do run across you know, answers after the fact, we'll be sure to try to get back to people. So so once again, I think we're caught up on these questions. So if you do have questions, if you're holding on to them, you know, please don't be afraid to get those in the chat box to us, or if it's a more detailed question, just send us a message and we can unmute your line, you know, to ask something more detailed if it's easier than typing a really long question. So getting back to HIPAA, I do want to reference that when we're using some of these devices in your practice, you know, please be cognizant of the devices that you're using these on. You know, so they have waived some of the HIPAA requirements, but once again, it is within good faith. So we want to make sure that if you're doing telemedicine on a device, we want to make sure that you're using an operating system that is currently supported. You know, I'm not sure what they're going to consider within good faith, but everybody knows currently that Windows 7 is no longer supported. So I would highly recommend that it is on a modern operating system that is patched with reasonable security precautions taken on it. So making sure it's up to date, making sure the device is encrypted, basic security practice. You know, this kind of suspension and loosening of the rules is not kind of a free for all. It is saying that, you know, if you're rapidly adapting to the situation and unbeknownst to you, you create you have a breach for some reason, as long as it was done within good faith, they're not going to find you. It doesn't alleviate your responsibility to ensure that the protections are in place. So, and that goes back to why we're still recommending a certified or a HIPAA compliant, you know, video conferencing solution, you know, if you're starting to do telemedicine.
Yeah, that is a very good point. That is something that has been coming up a little bit in some of the correspondence I've had. is, you know, looking for funding sources for rapid deployment. And, you know, I just want to reiterate Tom's point that while we are obviously developing telehealth service lines at warp speed, we still need to be kind of thoughtful about what we're doing. And it's interesting. I didn't get a chance to watch it as I was speaking on a Haney's call earlier, but Governor Cuomo did his normal, I think, noon address. And I had several people text me and say that Cuomo said to the masses, why haven't we been doing telemedicine before? Why aren't all of you ready to go with this? And it's just an interesting point that he's made, that this has been here all along, and there have been a lot of regulatory hurdles that have prevented all of you from really doing this, even if you feel that as an organization it is the right thing to do and it could be beneficial. So while those regulatory flexibilities are now in place, don't forget that it's probably going to go back to the way it was before. I can't see state and federal agencies, you know, just letting things kind of be so broad in scope right now. Right now they will, but after this pandemic is behind us, I have a feeling things will go back to the way it was. And are you setting up a program that's going to allow you to still provide services to your patients? I've been getting calls from practices telling me their patients love this. Their providers are actually enjoying it. You don't want to take that away from them when the pandemic is over. If they like it now, they're going to want to keep coming to see you without having to leave their house. So, you know, are we going to be able to do that in a post-pandemic world? I hope so, but just keep that in mind.
Yeah, and that's a good point. You know, and you know, to get back to Cuomo's comment is, yeah, telemedicine has been here, but you know, telemedicine traditionally has been an investment for a practice, and the way reimbursement rates had been going in kind of the moving target. Before the pandemic, it was a hard choice for people to jump in and make that commitment or that investment, in telemedicine. So, I wish that, we had equal reimbursement, because if that was the case, the year previous to this happening, I think you would have seen a lot more people have these capabilities in place, and we very easily could have provided telemedicine services, very easily, because they would have been in place. But the way the reimbursement had been going, it wasn't necessarily right for everybody. So it really brings up a good point. And I think now we've demonstrated how useful telemedicine is. And, I've had some people reference this to me as well, was, what happens when this is all over with. So I agree with you, Katie, that it's probably going to go back, but I think we have some really good real life scenarios of why we really need to consider telemedicine.
Yes.
Yeah.
So we've been getting a few comments just amongst the audience about dietitians billing. So I thank those of you who are providing some valuable input. Again, we still have 15 minutes. This is your opportunity to ask us questions live, which is not an opportunity that usually comes up. So we're happy to answer to the best of our ability. Pam Knowlton did make a comment here around therapy services are billed under ops. Are we to bill the same way with modifier 95? I don't know if you're referencing the therapy codes that were newly added as of Monday, but the newly added codes are to be billed with modifier 95 in the place of service at where the patient would have normally been seen. As a correction from earlier, the traditional telemedicine Medicare codes are still place of service code 02, but these newly added codes, such as the physical and occupational therapy, as well as hospital services, neonatal, pediatric critical care, intensive care, are using 95. So I hope that answers your question.
Good.
I honestly think, sorry, Tom,
No,
DOH has kind of done this too. So I was a little bit confused up until this morning. With DOH's 6-lane billing grid, they have put the GQ modifier, now this is for Medicaid, not Medicare. They have stated the GQ modifier is to be appended for 99211, which is a nurse providing telephone services with a physician supervising, as well as any existing procedure codes for services appropriate to be delivered via telephone from all other practitioners that aren't physicians, mid-levels, nurses, or dentists. So DOH is using this GQ modifier, which typically is the store and forward modifier, as a way to track telephone encounters. They're doing this so that, you know, when we get through this pandemic, they can look back and see, you know, statewide, we had X number of telephonic encounters billed because we have the GQ modifier tracking it. So I think the CMS change to use modifier 95 for the newly added codes is a way for them to track nationally the utilization in the pandemic.
excellent. So I did have kind of a question, and actually it was it's somebody from our office, and they're actually looking to kind of put a general question out there to some of the hospital partners. Tracy, I'm going to unmute your line if you want to kind of ask the question, and you know, if people have a response, they can kind of type it in the chat box. So I'm going to unmute you so you can ask that. All right, Trace, you're unmuted.
Hi guys, can you hear me?
We can.
Okay, thanks. So yesterday I was on a BHCC, Behavioral Health Community meeting with DOH and OASIS and everything. And a couple of the BHCC partners in the bigger cities were saying that the hospitals, because they have more manpower, are putting together like a condensed version of all the updates that are coming in from CMS, DOH, et cetera. And they're able to share it with some of the, you know, community-based organizations and the private practices that don't have the manpower to filter all these updates. So we were wondering if any of the hospitals are doing that, and if it was possible, if they could share it either to us and we can share it out to the smaller practices, or if we could help do that and then share it out.
Yeah, I think that's a great point. You know, if there are
the updates are coming in like 3, you know, you're getting 5-6 updates every day from somebody.
Yeah, yeah, agreed. So yeah, if there's entities out there that do have you know, more resources, and they feel that they've done a good job on kind of putting together summaries you know, of these updates, you know, if anybody has anything that they feel would be useful, you know, to be shared with the group, please, you know, please send it you know, to either Katie or myself. You know, we can certainly add it to both of the websites as a reference page. So, so yeah, I completely agree with that, but this goes for everybody. If you have something that is valuable, that you think is a resource, if you put some time and effort into kind of consolidating some of these waivers and updates into a summary, you know, shoot it over to us. We're doing a lot of the same work, so you may be saving us some time if you've already done it. So it's really a great point. If you have anything to share, please, you know, please get it over to both Katie and myself if you're willing to share it.
Thanks, Tom.
You're welcome, Trace. All right.
One of those such documents, Tom, Felicia just mentioned, is the Medicaid telehealth FAQ document. That's that 26-page document that I referenced earlier, and I'll be sure to send this out to the group after the session is over. It's pretty lengthy, it's pretty detailed, but you know, if you can't get your question answered in that, you know, they do provide a contact information, which lends me to a good point. And I'll type these into the chat box. So CMS has a specific email for COVID-19 questions as a whole. It's covid-19@cms.hhs.gov. Oh, it's hhs.gov, not HSS. I can't type. I imagine that email is quite busy, but if you can't find the answer from us or through researching on your own, that is one way to get information. CMS is also doing some pretty frequent calls. I know I was on 2 of them yesterday, where experts from CMS, including Seema Verma herself, are on the line answering your questions. DOH also has an email. I'm looking for it right now. I know it's like telehealth-policy@doh.ny.gov. I'm just trying to find it in this document. So give me a second. There it is. So I'm typing it in right now. It's telehealth.policy@health.ny.gov. So those are some, if you can't find the answer anywhere else, those are some ways that you can find more information.
Excellent. Those are great references. As well, if you have something that, you're not comfortable asking in front of the whole group, you can always email Katie and myself directly. If it's, as you can tell, if it's more billing and things like that, that would probably be more in Katie's lane. If you send me a question, I'm probably going to end up refer it to, probably to her. I'm very heavy on the technology side and the security side of it than the billing portion of it. So, if you're doing the implementation, if you need some high level guidance, shoot me an email. I'd be glad to give you my expertise when it comes to health information technology. As well as I know Katie was going to do everything that she can to potentially answering, a billing related question as well. So we still have a little bit of time. This is one of those rare opportunities. We don't have open forums very often, mainly because we can't control the content and it's on the fly. So, but I really thank everybody for the great questions. It's been really, really, really good, I think, so far. So, we're wrapping up here towards the end. So if you do have any other questions, get them into the chat box. We're going to continue to try to answer questions right up into the hour. Whether it be billing or whether it be technology, just kind of let us know.
Yeah, and just hold on. Oh yes, I am unmuted. Just relating back to the original behavioral health question, the DOH Medicaid telehealth FAQ document that just got released actually has a few sections on behavioral health. So when I send that document out momentarily, I'll try to get that out this afternoon. Refer to that section. It may provide a little bit more guidance, but again, if you have questions in that behavioral health substance use spectrum, we are going to focus solely on the OMH and OASAS side of things tomorrow.
Yeah, excellent. And it's one of those things, we didn't, it's not that we didn't want to answer your behavioral health questions, but it is kind of its own unique kind of thing. So, and a lot of the people that are going to want similar answers are all going to be on the webinar for tomorrow. So, we try to cover it quickly, but if you do have specific questions, like Katie was saying, we'll certainly address those tomorrow. So, any other questions? I think everything's kind of quieting down. So, we'll kind of do last call for questions. Once again, if you have any technology questions or you need to run something, from a technology standpoint, please reach out. Both my email and Katie's are listed there. So, so please use us. Send us your questions, and we'll do everything that we can to get back to you. And yeah, thank you guys for the responses. There's no need to thank us. You guys are really the ones, in the front lines at these hospitals and at these clinics and rendering the patient care. This is, we're trying to be, here in the background and trying to do as much as we can to support you guys. So no need to thank us. Thank you guys for everything that you're doing during this crisis. You're really the ones that are out there and seeing patients and treating these patients trying to protect yourselves with the limited PPE and things that you guys are, struggling to get. So thank you guys. We really appreciate it. So, last call for questions. If you got a question, get it in the chat box. We'll try to get it answered, and I'll kind of hand it back over to Katie to see if she has anything else to add in here before we kind of wrap up.
Nope. We're just, trying to work through all of this the best we can. When in doubt, look at our websites. Our communications teams at our respective organizations have been doing a really great job in getting the information on our websites in a timely fashion. To the tune of every morning, I'm emailing our respective communication teams to put up, 5 more documents that came out. So that's the best source of information to start with. And then, of course, reaching out to us directly. And I echo Tom's sentiment that, we are obviously here for you. And, thank you guys for doing what you do. We're just here to support and make sure you have the answers you need. So there haven't been any other questions. So I think we're safe to wrap it up for the day.
Excellent. Well, once again, thank everybody for attending and the great participation and some of the information that even you guys provided. So there was references you guys kind of helped us out with. So it's definitely, teamwork. So once again, thank you for everybody for joining us today. Thank you, Katie, for all your help. I think you did way more talking than I did. The billing and coding was definitely way more popular than the technology and the security.
Yeah.
So, but once again, don't hesitate to reach out if you need anything. We're here to help, and thank you guys for attending. And we'll be doing this all again tomorrow for the behavioral health side of it. So take care, everybody. Stay safe and stay well.
Have a great day, guys. Thanks.